Picture this, you wake up at 2 a.m. with chest pain. You don't know if it's a heart attack. You go to the emergency room. Doctors run tests. They tell you it's not serious anxiety, most likely. You go home. A few weeks later, the bills start arriving. Not one bill, 3, 4, 5, one from the hospital, one from the emergency physician group, one from the radiologist, one from the cardiologist who reviewed the scan from across the country and never entered your room. When the final accounting is done, a visit that lasted 5 hours and produced no diagnosis costs $11,000. You have insurance. Your portion, after deductibles and coinsurance, is $4,000. You don't have $4,000. In 2024, the United States spent $5.3 trillion on healthcare. That is $15,474 for every single American, man, woman, and child. It represents 18% of the entire U.S. economy. No country on Earth spends remotely close to that per person. And yet, by nearly every major health outcome metric, life expectancy, infant mortality, maternal mortality, chronic disease rates, the United States performs worse than most of the countries it otherwise compares itself to. This is not a broken system. It is a system working exactly as it was designed to for the people who designed it. To understand why Americans pay more and get less, you have to start with a number most people have never heard. In the United States, administrative costs consume approximately 30% of every dollar spent on healthcare. Not care, not medicine, not research, administration, billing departments, prior authorization teams, claims processors, denial specialists, appeals coordinators. An entire parallel economy built around moving money between patients, providers, and insurers, without producing a single unit of health. In Canada, that number is 12%. In Germany, it is approximately 13%. The gap between the American administrative burden and the peer nation average represents, in raw dollar terms, over $800 billion per year. That is not a rounding error. That is more than the entire GDP of the Netherlands, spent annually, in the United States, on paperwork. Every doctor's office in America employs more billing staff than clinical staff in many cases. The average American hospital now spends 25 cents of every dollar it collects navigating the insurance system. That cost is passed directly to patients. Now here's the thing, the administrative burden is not accidental. It is the product of a specific business model, one in which private insurance companies profit most when they pay out least. In 2024, health insurers denied 19% of all in-network claims filed through ACA marketplace plans. Nearly 1 in 5. The reasons given range from medical necessity disputes to coding errors to prior authorization failures. Most patients do not appeal. Most who do appeal lose. And the insurance company keeps the premium either way. United Health Group, the largest health insurer in the United States, reported over $12 billion in profit in a single year, while simultaneously deploying AI systems to accelerate claim denials at scale. A federal lawsuit alleged that one such algorithm had a denial error rate of 90%. 90% of the care it denied should have been covered. It denied it anyway. Because the incentive structure rewards denial, not care, the American health insurance system does not exist to pay for your health care. It exists to collect premiums, manage risk, minimize payouts, and return value to shareholders. Your medical claim is a cost to be managed. Your health is not the product, you are. The insurance denial system is only one layer. Beneath it is something even more opaque, the American hospital billing architecture. Every hospital in the United States maintains what is called a chargemaster, a master list of prices for every procedure, supply, and service it provides. These prices bear almost no relationship to what anyone actually pays. They are negotiating anchors, set deliberately high so that the final negotiated price with each individual insurer appears to be a discount. The uninsured patient, the one with no negotiating power at all, is often billed the full chargemaster price. A basic blood test listed at $800, a saline drip at $700, a single Tylenol tablet administered in a hospital charged at $30. These are not anomalies. They are the system. The result is that two patients in the same hospital room, receiving identical care, can receive bills that differ by thousands of dollars, based entirely on which insurance company they happen to carry. And if they carry none, they receive the largest bill of all. But here is where it gets darker. because even if a patient navigates the insurance denials and survives the hospital bill, they still have to pay for the drugs. The United States is the only major developed country that does not regulate pharmaceutical prices at the national level. Every other peer nation, Germany, France, Japan, Canada, the United Kingdom, negotiates drug prices with manufacturers. The U.S. government, by law until very recently, was explicitly prohibited from doing so for Medicare patients. The result is that Americans pay 2 to 3 times more for the same branded medications than patients in comparable countries. A monthly supply of Humira, a widely prescribed arthritis drug, costs approximately $6,000 in the United States. In Germany, the same drug costs approximately $1,300. The molecule is identical. The manufacturing cost is identical. The price is not. Insulin, which has been synthesized for over a century, costs an average of $330 per month in the United States. In Canada, across the border, the same insulin costs approximately $30. Americans have driven across that border to buy it. Some have rationed their doses because they could not afford the full supply. People have died managing a condition that has been treatable for over 100 years. And at the end of all of this, the inflated premiums, the denied claims, the chargemaster bills, the drug prices, comes the debt. 100 million Americans currently carry some form of medical debt. That is roughly 1 in 3 adults. In 2022, approximately 41% of U.S. adults reported having debt due to medical or dental bills, money owed to hospitals, credit card companies, collections agencies, or family members who lent them cash to cover a bill. Medical debt is the leading cause of personal bankruptcy in the United States, not gambling, not poor financial planning. Getting sick. What happens to that debt once it exists is its own system. Hospitals sell unpaid medical bills to debt collection agencies, sometimes for pennies on the dollar. The collection agency then has full legal authority to pursue the full amount from the patient, to call them, to report them to credit bureaus, to sue them, to garnish their wages. The patient's medical crisis becomes an asset on someone else's balance sheet, and the collection system is designed to extract maximum payment from the people least able to pay. Because the people most likely to carry medical debt are lower income, uninsured, and already financially strained, they cannot afford lawyers. They cannot easily navigate the appeals process. They often don't know that hospitals are legally required, in many cases, to offer financial assistance. They pay what they're told to pay, for as long as they can, and when they can't, it follows them anyway. About 1/3 of American adults say they have skipped or postponed medical care they needed in the past 12 months because of cost. 4 in 10 say they have not taken medication as prescribed, skipping doses, cutting pills in half, going without, because they could not afford the full prescription. This is not a marginal phenomenon. It is the daily reality of tens of millions of Americans making medical decisions based not on what they need, but on what they can survive financially. There is a well-rehearsed response to everything you have just heard. It goes like this: Americans are unhealthy because they make poor lifestyle choices. They eat badly, they don't exercise, they smoke. The high cost of American healthcare is therefore, at least in part, the product of American behavior. If people took better care of themselves, the system wouldn't cost so much. There is a kernel of truth in this that is used to carry an enormous lie. Yes, chronic disease driven by diet and lifestyle contributes to healthcare costs, but the countries with universal healthcare systems and regulated drug prices also have populations with chronic disease. The difference is that their citizens are not bankrupted by treating it. The personal responsibility narrative serves a specific function. It redirects attention from the system, its pricing architecture, its insurance incentives, its administrative waste, its pharmaceutical pricing regime, and places it on the individual. You are the problem. Your choices created this. If you want to blame someone, blame yourself. Meanwhile, the architecture remains untouched. The premiums keep rising. The denials keep coming. The bills keep arriving. So what would actually help? The answer requires looking at what works, not in theory, but in practice, in countries that spend less and get more. Every peer nation that outperforms the United States on health outcomes does so through some version of 2 mechanisms. First, universal coverage, the removal of the insurance gatekeeping layer entirely, or its replacement with a tightly regulated nonprofit system. Second, centralized drug price negotiation, the government buying on behalf of the population. creating the leverage that individual patients categorically cannot have. Neither of these ideas is radical. They are the default in nearly every wealthy democracy on Earth. The United Kingdom, Canada, Germany, France, Japan, Australia, none of them face the uninsured crises, the medical bankruptcy rates, or the drug pricing disparities that define the American system. They built different architectures, and they get different results. The Inflation Reduction Act of 2022 gave Medicare the authority to negotiate drug prices for the first time, a significant shift, affecting a limited initial list of medications. It was the first crack in a wall that had been legally maintained for decades. It was also immediately and aggressively challenged by the pharmaceutical industry in court because the architecture defends itself. It has lawyers. It has lobbyists. It has campaign contributions. And the patient in the waiting room deciding whether to fill the prescription does not. The American healthcare system is the most expensive in the world. It is not the most effective. It is not the most equitable. It is not the safest. It spends 30 cents of every dollar on administration. It denies 1 in 5 claims. It charges patients prices that are legally untethered from cost. It prices medications at multiples of what every other wealthy nation pays. And when the bills are unpaid, because they frequently cannot be paid, it converts a medical crisis into a debt that follows a person for years. This is not a broken system. A broken system fails by accident. This system succeeds by design. For those who designed it, understanding that is the first step. If this video gave you a clearer picture, share it with someone who needs to see it. Next week, we are going to show you exactly how the American retirement system was redesigned, not to help workers retire, but to give corporations a permanent, legal exit from one of their most expensive obligations. Subscribe so you don't miss it. We'll see you then.